Okay, thanks everybody for coming, especially on a wet, snowy, sleety, gloomy of nighty day. I think I've met all of you, except, no, yeah, everybody.
No.
So,
Oh, yeah, no.
yes.
Not from last year.
No, just from recent introduction, so I won't do that again. So let me introduce myself. I guess you know a little bit about me, but my name is Richard Kohl. And I've been working on scaling up for about 10 years, pretty much full time actually. I actually do have a PhD in economics, but I discovered that, that most of what I learned in graduate school doesn't really apply to scaling up, though actually worrying about incentives is important. But most of what I do is basically get inside the black box between concept and large-scale implementation, and I hope that's what we're going to talk about today. The way I got into the scaling up business is I have a guardian angel who has a very ironic and sardonic sense of humor, and about every 5 or 10 years, he or she, do angels have gender? No, probably not. It. Okay. Actually, I was just in Ireland working on scaling up, and I was in Belfast, and I said, so I was about to say in this country, and then I realized, well, it really wasn't a country, and I wasn't sure if it was a region or a province. So I asked, how do you refer to it here? And the Catholics and the Protestants proceeded to have quite an argument for about 20 minutes. And the only thing they could agree on was here. So I proceeded to refer to Northern Ireland as here for the rest of the 2 days I was there. So anyway, my guardian angel has a very funny sense of humor, which is about every 5 or 10 years, he or she or it says, why don't we make him do something completely different that he has no background or experience in? So about 10 years ago, I was working for a pretty well-known USAID contractor. And the MacArthur Foundation approached them and said, we plant all these seeds, we fund all these proof of concept programs around the world, particularly in reproductive health. Some of them are wildly successful, are published in major refereed journals, particularly like The Lancet, and they don't go to scale. And we thought that just doing something and having it work was sufficient to go to scale, but it turns out not to be, at least in our experience. And so would you be able to develop and implement a strategy to support them in their scaling up? And I co-authored with the and at that point I knew nothing about scaling up, nothing about reproductive health or maternal health, which was their 2 big fields, and I had never been to either India or Nigeria, which were the 2 major countries they worked in. So my boss thought I was the perfect person for the job. So I found myself on a plane to Nigeria a few weeks later, and I guess that was 10 years ago. So I've been doing scaling up pretty much nonstop. I've worked in a lot of sectors: education, health, early childhood development, anti-poverty, particularly rural poverty, and agriculture. And I've worked probably in about 20, 30 countries, and increasingly actually in the US and Canada. So what I'm going to share with you today is how I think about scaling up and would suggest you think about scaling up. And I hope that, I think you'll see that as we go through some of these ideas, that there are a lot of things that you're already doing that are really good and that are really aligned with scaling up. But there might be some holes that we might want to fill, and we can discuss that definitely after my talk. But I have a lot of slides because I am not only going through concept, but I'm going to try to illustrate it with a case study from a project I worked on in India that did go to scale, which I think is a pretty good example of both the successes you can have and some of the compromises and trade-offs that you have to make. Because I'm doing both concepts and application, it's a lot of slides, and I think we'll all fall asleep if I talk nonstop for 2 hours and it's only me. So therefore, I would really like this to be interactive, so please stop me and ask questions. The worst that'll happen is I'll say, actually, I've got a slide on that in about 3 slides, so can we just hang on for a second, and if that doesn't answer your question, then let's discuss it then. Is that good? Okay. Away we go. So, page down. So I think as I've kind of already said, the major problem with scaling up historically is that people take it for granted. They think that if you do a small pilot project in the field, and we could also discuss what a pilot project is versus a proof of concept project, but let's get to that one later. Build it and they will come. If it works, the world will beat a path to your door. And I think in some cases that does happen. Spontaneous scaling up does happen, but one of the research areas that maybe JPAL or IPA or EPOD, is EPOD here yet? Not yet, okay. Could do is we actually have no idea how many things actually go to scale spontaneous like that, and why? Which ones do and which ones don't? What the political economy conditions are that allow that to happen on the one hand, and what the nature of the particular concept is that are more suited for that. But I can tell you from personal experience and having worked in the field for 10 years, my guess would be at max is 15%, and probably closer to 5 or 10 on average, like 1 out of 10, 1 out of 20 is the ballpark. But I'd be curious what your all experience is. And I think the reason for that is that most people who do proof of concept stuff tend to be academic researchers or people who are doing pure research. And they believe in evidence-based policy making, and increasingly so do most bilateral donors and international organizations and developing country governments, at least in theory. But in practice, that's actually not what happens. Despite having gone through Mark's fantastic course on that, they still are subject to a lot of political pressures and a lot of implementation pressures. And so often, I mean, if you look at the website for the government of India, pick your sector, health, education, I don't care what it is, their policies are fabulous. I mean, world class, often a lot better than they are in most OECD countries. But if you look how that translates into programs on paper, and then how the programs on paper translate into practice on the ground, the gaps are huge. Okay, so I think the problem is that evidence is necessary but not sufficient, contrary to the assumption that it is sufficient, and B, a lot of the work we do, I think like the JPAL policy team, which is often called research into practice or stuff like that, I like to think of as rest in peace. That basically it's going to end up as a strategy document on a website, and it's never going to go beyond that. And so I think one of the questions that we need to talk about today is what more needs to be done, and how much of that does JPAL or IPA feel like it's in your mandate to do? Okay? And I do want to say, however, that I think that JPAL has really, and the work of IPA and JPAL and its associated organizations have really raised the bar dramatically on the quality of evidence. But again, it's necessary but not sufficient. It's great now that we know that the stuff we're trying to scale actually works, as opposed to maybe the case 15, 20 years ago, where there was some qualitative evidence, but that's not going to get it done. Okay? So what I'm going to talk about today is I'm going to go through a few definitions. We'll talk about a scaling up framework, and then we're going to apply it to a model that was developed by Search, which is a research-based health NGO in rural Maharashtra. That was on home-based neonatal care that is currently being scaled in India, and some lessons learned from that. All right? All right, concepts and definitions. So first of all, the two key concepts I really want to get across today, among others, is the difference between capacity and capability. So usually in our field, international development, we talk about capacity building. And actually, that's incorrect English. Because capacity, what's the capacity of this class? It's probably, what, an 8-ounce glass, maybe? Okay, cup. So basically, capacity is a measure of quantity. But when we talk about capacity building of an organization or a system or a ministry, we're actually talking about ability, right? What can it do, not how much of that can it do. Very rarely do we say, oh, we're going to do capacity building in organization X so it can do twice as many things. We usually think about doing them better, so we give them training. Training doesn't allow you to do more things usually. Well, sometimes it does, if it's new stuff, but it usually allows you to do existing stuff better. So when Mark and his team, teach about evidence-based policy making, or running RCTs, or designing them, monitoring them, implementing all that kind of stuff, some of that's new, but some of that is basically how do you do policy-based research effectively. And usually the organizations that he's working with already do that stuff, they just don't do it very well. So they're doing it better. So actually what he does is not capacity building, he does capability building. But we have gotten into this habit. Now, I say that not because I had an undergraduate degree in English and I'm a stickler for this kind of stuff, but the reason it's important is because if the capacity of this is 8 ounces and the capability is that it holds water, it's waterproof or holds liquids, right? For scaling up, we need both concepts. And if we use capacity to talk about volume or quantity, then we got nothing, and also to talk about ability, then we have nothing to talk, then we're using two words, the same word twice, and then we get into trouble. Because if we want to scale this up, or if you want to scale up any concept, right, we need to do it at a larger scale, more quantity, more capacity. Somebody has to have large capacity to deliver that, and yet we still have to have the capabilities to deliver that particular concept. We need both. Does that make sense? And the reason I'm harping on this distinction is because, generally speaking, it's a tension, okay, between the two. I mean, again, I don't mean to pick on India. It's just the country that I know the best because I worked there for about 6 years. I was there 3, 4, 5 times a year on working on about a dozen, scaling about a dozen projects. And generally speaking, what we would find, particularly in health, was that a lot of NGOs had great capabilities. They could deliver really good projects at a local level, but very limited capacity. Very few could work outside maybe a few districts, or at best a state. Very few. I don't even know of any actually in health that work in multi-states. Actually, I know of one because we scaled it to multi-states. Okay? But I'm not going to here to quibble about that, but I think the point's obvious. Whereas the flip side, on the government, the national health system has huge capacity, in principle at least. It can deliver in all 36 states down to the primary health care level. But its capability to deliver programs effectively or concepts effectively is fairly limited. So as we'll come back to in this later in the presentation, that was the constant tension. Well, if we go through the government system, we're going to get large-scale delivery and crappy results. Or if we go through NGOs, we're going to get small-scale delivery and really good results. And how do we finesse the capability capacity challenge? And we can talk about that later more. Okay? So I want to just talk also, be clear on what we talk about scaling, because scaling could be, there are multiple definitions of scaling, but I'm going to focus on two, which I'd like us to use from now on, and also be clear about which of the two we're using. One is to scale the impact and scope of the concept of itself. Okay? So what I mean by that is, let's say, for example, we have an antenatal care model, which is going to reduce neonatal mortality and morbidity. All right? And the core of the model in its first cut is 3 antenatal visits. All right? We could scale the model or the concept by adding complementary services to it. So for example, in my example about antenatal, suppose every time a health worker would visit a pregnant woman, she would also provide micronutrients. Okay? That would be adding something to the model. Same number of people or locations or demographics that it's being scaled to, but the model changes. It gets bigger. Okay? Actually, I would say, or instead of, we could go more dosage, more depth, which is from 3 antenatal visits, we decide, well, let's experiment, let's do an RCT. There's a difference between 3 and 6 antenatal visits. Does that give you increased outcomes? So that's a scaling the model itself or increasing quality. Let's say, for example, that the health workers originally got 1 week of training. We want to see if they get 3 weeks of training, does that improve outcomes? So those are all 3 dimensions of seeing whether the dosage, the breadth, the depth, the quality of the model makes a difference. And JPAL or the researchers or IPA could prove that something works. And one of the feedback could be, well, let's scale the model itself. Let's see if more of the same gives you better results and what's cost effective. Now, what's key about this is actually often in scaling, you want to go the opposite way. Well, actually, that's not true. You can either go either way, but you can often not only scale up in a sense from this perspective, but scale down. That generally speaking, the more simple the model, the easier it is to scale. Okay? So there's a tendency, particularly in fields like health and education, I work a lot in early childhood development, to do comprehensive models. We're going to do education, we're going to do health, we're going to do malnutrition, we're going to do psychosocial development. Well, one of the challenges, especially if your primary vehicle for scaling up is a government, is that generally speaking, those don't sit in one ministry. And when you try to start coordinating implementation across 2, 3, 4, 5 ministries, it becomes very difficult, especially given the original challenge. If the ministries are weak in terms of implementation capacity, together, so let's multiply that problem times 5 and add coordination on top of it, that can be a big challenge. Okay? Secondly, often when we're talking the implications of a complex model or a sophisticated model is it requires, nobody's going to pay for a month or 6 weeks of training. Nobody's going to give a health worker or a nurse or a teacher 6 weeks off to go attend your training. And so whether it's the cost in terms of time or money or simply can't deliver that kind of intensive training, they're going to say, that's great, glad it worked, but we don't have the capacity or the capability to do what you've designed and implemented, so we want to cut it in half. Okay? We want to scale it down to scale it up, in a sense. All right? And I think to some extent you do this, but one of the things I always pitch, I always talk to Mark about in particular, is thinking about building scaling up into your research from the beginning, because if there's a good chance that scaling down the model itself is likely, then can you build into your research methodology, somebody says, this cost $150 a kid, or an adult, or a pregnant woman, and it takes 6 weeks to train a field worker. We're telling you we can't do it at scale. We can do $75 a kid, or a mom, and 3 weeks of training for a health worker. So get your program into that box. Now, the easiest way to do that is if you've actually analyzed the cost effectiveness of subcomponents of the model at some point. Now, that could be in a second stage research, but that's often a key thing for, since evidence-based policy is the name of the game in this organization, or these are your organizations. Generally speaking, when I've had those conversations, even with organizations that have done RCTs, they can't disaggregate. They don't have any quantitative data on the components, either for cost or cost effectiveness or impact, and therefore those judgments are made qualitatively, which is precisely what you're all trying to get away from. Okay, so for scaling, we'd like to have evidence like that. Yeah? Which could, if you can't build it in the first time, then if you start to do replication, should we replicate 2 or 3 different versions with different dosages at different cost points and see what we get? Yeah? Making sense? Yeah, okay. All right, so the other one is the more obvious and common use of scaling, which is reach, what I call reach, just because I don't want to define scale by scale, not helpful. And that could be demographics. So for example, we could go from, if it's a youth, you guys do youth, right? Yeah. So it could be youth. In some countries, they define youth 15 to 25, other countries 15 to 30. I was just in Rwanda evaluating the scalability of a youth livelihoods project. It was a USAID project which defines youth as 15 to 25, but Rwanda defines it as 15 to 35. So the project was done as a pilot at 15 to 25, but it's really, actually, for a lot of reasons which I could talk about if you want later, makes sense to scale it from 15 to 35 in addition to reach, in addition to other places. So you could have types of beneficiaries, locations, it was mostly done, this one was mostly done in Kigali, or peri-urban Kigali, and coverage. You could hold the location of the demographic group constant, but you could go from, let's say, 25% of that group in that place to 50% or 75%. I hope it's obvious that these are not mutually exclusive, right? We could go from one group definition of youth to a larger definition, from one location, Kigali, to all cities in Rwanda, and from 25% coverage in those areas to 75% coverage, all simultaneously, or any combination you want, right? So just to be clear, 2 definitions, scaling up the model and scaling up the reach, and within each there are multiple subcategories. Any comments, questions, clear? Yeah? Good? All right? All right. So if we put all this together, and by the way, a lot of the stuff I'm going over is not because I'm, again, a stickler for, I have OCD. I don't have it, actually. I've got lots of other issues, but that's not one of them. All right? Is because there are particular, what's the right word? Challenges or common mistakes that I see in scaling up that I'm going over this stuff with to anticipate. So let me do that deliberately. So the reason I define scaling up, and I'm using it as going to scale, as a process, not as the endpoint, of sustainably increasing the reach and potentially the scope of a promising or proven program with fidelity and quality, thereby retaining some or all of its demonstrative positive impact. Right, so what are the straw men that I'm knocking down here? Well, first of all, lots of times I see things scaled up that aren't sustainable. Right? You come back 5 years later and they're there. Okay, why does that happen? Because basically we do a one-off training, right? And we'll talk more about that. Secondly, I see lots of stuff scaled up that's not promising or proven. Okay, that's your job, right? To make sure it is. Okay, I'm using the word program because I wanted to define program. What's the word you use for it? A scalable version? Is that your term?
Yeah, well, yeah.
Okay,
Concepts and
right. Right, so I'm using concept as embedded in program to identify both the concept and the implementation structure. How is this delivered? Okay, and I'm using the terms fidelity and quality to mean that it's somewhat similar, if not identical, to what was proven, okay, so that we're not just about increasing reach, but we're about retaining some of the positive impact. Because I cannot tell you how many times I see stuff go to scale. I'd say it's probably the majority that bears little resemblance to what was done at small scale. Okay? Again, not to pick on India, but is anybody familiar with the ICDS program, Integrated Child Development Scheme? Right? It was piloted in the late 70s. It looked pretty good at the pilot level, and it's had absolutely no impact on most child indicators in India, despite the fact that it's in every village in the country, and it costs a lot of money. Okay? It was supposed to be, it's a good example of a comprehensive program in design, where it was supposed to do psychosocial, teach parenting skills, and it's basically sort of was, as it was scaled up, was diluted to a combination of nutrition hot meals program with a little bit of babysitting and a tiny, tiny, tiny bit of psychosocial development thrown in. And basically the malnutrition stunting indicators in India for children have barely moved in the 30 years that the program has been around.
So actually I think last month they came out with a new report, stop taking over. Every 5 years they publish this report, and some states have actually sort of really changed and they've improved, but then there is a lot of concern on data quality and how they've actually collected data, and then collecting data to prove a point and stuff. So it's one of those controversial schemes because the government of investment is bringing in government. So.
Yeah. Well, the reason I'm in Cambridge and was able to spend time with you is that I'm actually teaching a module on scaling up for a Harvard leadership course for early childhood development leaders. And we had dinner last night with the head of the Van Leer Foundation, which is the largest funder in the world of pilot programs in early childhood. And I was talking to some of the people at my table, and we were saying, you know, India is really interesting because it's like the anti-Cuba, right? Cuba, if you do a regression of early childhood indicators on GDP, Cuba is way, way, way above where it should be. And especially given the growth in India the last 20 years, India is way, way below where it should be. And I think that that's basically because even though the policies are great, they're implemented poorly. And I think ICDS is a good example of that. Okay? No? Okay. All right. So, so now that we've talked about a few definitions, let's talk about how we're going to do this. And so most of the time, I think this is what, in principle, successful scaling up looks like. Okay, this is an example of good practice or process. So first of all, there is a model or a program. I'm going to use those words interchangeably, which I didn't know you used the word concept, or else I would have put it in there. But I'm using the word intervention here as the way you use concept. Okay, plus an implementation process. There's some delivery mechanism, right? Okay. Once we have this, excuse me, we then need to make sure the model is ready for scale. So we need to make sure it is promising or proven. We often do need to simplify it. Sometimes we need to complicate it. And let me just say a word about that. A lot of the net takeaway you should get from this talk is that there are lots of ways to scale up, and we could talk about their pluses and minuses. And there's lots of steps to it, and somebody needs to do them or else it doesn't happen. But the third thing you should get is that most of scaling up is the two pieces of the puzzle that you do less of, though some of, which is you need a model that's proven, and then there's politics and implementation. Okay? And most of what I'm going to talk about is politics and implementation. So the reason sometimes you need to complicate it is you need to rebrand it. I used to work a lot on family planning models. In the 1990s, family planning was really trendy, and there was lots of money. And then HIV took off, and all the money that used to be in family planning went into HIV. So I'd work with these family planning models, and they'd say, well, there's no money for scale. How can we do that? And I said, well, don't you include training on HIV in your program? Oh, yeah. We have significant outcomes on that, actually. I said, so why is this a family planning model, not an HIV model? So that's, in some cases, just either a rebranding or adding an HIV component was often very successful in getting something to scale. So that's a question of complicating a model to put it in the policy window, which is currently hot, right? Okay. We need to know what it is. Just because it works, often models aren't documented and how much it costs. We then need a strategy. We'll come back to this. Where, what, how, and who. And I actually do it in that sequence. So that's important. What are the goals of scaling up? What's the model or program? How are we going to deliver it? And who's going to do the key actions? And then somebody's got to do advocacy to convince organizations to sanction. That means they're going to agree to do it, fund it, manage it, and implement it. And actually, we could probably add monitor there as well. By the way, you're very patient to sit through this like the third time. Okay? Then once we do that, we need to basically create capacity and capabilities. And actually, I would argue even add the enabling environment. There are often policy, regulatory, legal obstacles to something being scaled. I actually had a very interesting case. I worked with a team in Jordan where basically, because even though it's a very liberal Arab country, nonetheless, there are very serious restrictions on family planning, and they got a permission to do an exception to allow nurses to insert IUDs in women. And it was hugely effective in the pilot level. But all the OBGYN society and all the people in the Ministry of Health are all men. And they're all doctors. And they refused to allow nurses to do this at scale. And so that was the principal obstacle, was the enabling environment, or I guess you could call it, but it was illegal. It was illegal. So how could we change that? And I could tell you that story later, maybe over a beer or something. All right. Then implementation at scale. Actually, how do you get this, now that you've built the capacity and capability to deliver it, how do you actually roll it out? And particularly, how do you make sure it's done, you balance between quality and fidelity. Everybody know this jargon, fidelity? You know, there's a big literature now on implementation science. So if you haven't checked it out, get on the web and type in implementation science NERN, which I think is the National Implementation Research Network, and they have a wonderful working paper that summarizes all the implementation science literature. Unfortunately, most of it's domestic, and it's mostly in health and education. But actually, this is another area where I think both JPAL and IPA could do some really interesting work, which is taking the implementation science research and starting to apply it to what works in developing countries. Okay? Which is, again, the flip side of the concept side, which is if concepts are about, the technology, then they're about the implementation process. How do you get a proven concept to actually replicate effectively in different organizations and different concepts? That's what all the research is about. The only reason I don't like the implementation science research is it misses the middle step, which is the politics step. So it kind of just hand waves that and it says, okay, Brigham and, Brigham and Women's, is that what it's called? The hospital? Sorry, I haven't lived here in a long time. I lived here when I was 13. Brigham and Women's does some research, shows that X works, and 500 hospitals in the country want to do it. This research is about how do you make sure that that's done well? And the answer is, generally speaking, it's not unless you do certain things. So it would be interesting to replicate the implementation. Yeah?
So given that in the real world, implementation is often very crappy, it seems to me that there are basically two ways that you could respond to that. One is you evaluate what works in a very controlled environment, and then you build the capabilities of organizations to implement it on a larger scale. Right. I think that's the model that you're sketching out. It seems to me like another way to look at it would be implementation is really crappy, so we're going to test things that even crappy implementers can do at scale. And I feel like in our world, I think we've had a fairly permissive attitude toward evaluating sort of gold-plated interventions, in the sense that we talk about that as a proof of concept, right? Like, yeah, maybe this isn't going to be within the capabilities of organization X or government X to scale up, but we're just sort of establishing that this is a sensible concept. I worry that sometimes you sort of jump from that to, okay, let's scale it up, without looking at that in-between thing, which is like, what does this look like in a crappy implementing environment?
Oh, you want to piggyback?
No, yeah, there's this paper, I think it's Sendel and some other people, they wrote about how there's bias because of the way we select organizations that we do RCTs with, that they are a different type of organization, and so our results are kind of always going to be biased up.
So I'm going to talk about this a lot, but I did skip forward to how I address this. I'm sorry, I forgot your name. Sean. That's because I didn't know your name. Okay. So Sean, that's not what I'm advocating, actually. I'm advocating A, B, C, D, and all of the above. Okay, so certainly it is the case that capability building is one of the solutions. But my experience is that the larger the gap between existing, first of all, in this particular case, I want to use capability building to include cultural change. And I mean culture, I mean organizational culture, okay? Because especially if most of your implementation is through NGOs, which tend to have one type of culture, and most of your scaling up is through the government, which often have a very different culture, you can't implement concept X in institution Y because it's not aligned. It's like, you know, you're trying to put a round peg into a square hole, or whatever the right metaphor is, okay? And so capability building isn't simply like teaching a bunch of health workers how to do it, but their whole supervisors, all the incentive structure, which you guys spend a huge amount of time on, is completely misaligned, right? Which is basically, I think, organizational culture is sort of a fancy name for the collection of incentive structures in an organization, okay? And once you get into that game, okay, it's not a free rider problem. What's the right game theory term here? But basically, for a small intervention, does it really make sense to try to shift the entire organizational structure of the Ministry of Health or the health system in a country the size of India? Okay, it's just not worth it. Now, if you're doing 20, then it makes sense, and maybe sequentially you may end up doing 20, but for any one, and so there's it's not a free rider problem,
like a coordination constraint,
or a free rider. I guess it is kind of a free rider problem, or anyway, whatever the version is. So I tend to discourage this actually. Okay. So the question is, if you have a model, remember it's both a concept and a delivery mechanism, a set of goals at scale, which we'll talk about what they are, but should include impact and not simply outputs, right? And we have a method, which is, let's say, getting the government Ministry of Health to do it. And usually what happens is this doesn't line up. So I agree with you, Sean, we're usually very sloppy about this, which is basically this organization can't implement this model to achieve these goals. Because either it doesn't have the capability to do it well to achieve the impact goals, or it doesn't have the capacity to deliver this at the desired scale. Or sometimes both, a little bit of both. Okay? You're right, one solution is either capability or capacity building, but I tend not to favor that for the reasons I just outlined. So then you have the following choice. You can either, excuse the language, dumb down the model, or to be nicer about it, simplify it. In which case you want to say, okay, given the capabilities, what should we do? Okay, and how do we align the model? And at what stage do you want to do that? Do you want to first test the gold-plated model and then look at the bronze version? Or do you want to say what I call the Apollo 13 model, which is basically I'm going to lock you in a space capsule, you know, 1 million miles from the Earth, and you've got, you know, baling wire, scotch tape, bubble gum, and paper clips, and you've got to fix the life support system. So you say, our ultimate goal to begin with is to scale this up through the Ministry of Health or the ICDS system, the Anganwadi workers, pick your poison, okay? And this is what they're capable of doing. Can we design something that works in that environment? Okay. And so the question is, do you want to start from that point, or do you want to do gold-plated to bronze? Or alternatively, you can sort of say, well, we're going to stick with our people, you know, this organization, we're going to stick with this model, we're going to have more realistic expectations of the goals. So basically that if this reduced, you know, natal deaths at the pilot level by, you know, from 150 per 1,000 to 50 per 1,000, we'll think we'll get half that. And we're okay with that. You know, we're going in eyes open, which is okay. Or any of the above, which is we could simplify the model, we could be more modest in our goals, and we could do some capability building. And I don't have a right answer, but I guess my point is, to answer your question, is we need to go around the circle until the pieces align. Until we think we have the capability building and the resources to do this, we think it's realistic in terms of how far the system will move, okay? That we think that the version of the model is reasonably implementable by that organization, or we're expecting a certain amount of slippage and we're okay with that. And given all that, we've set goals that are consistent with the other pieces. But right now, that's not what happens. Okay, what happens is that these are done disparately, and then we end up with a mess. And we often, and so the reason we were all the way back like 30 slides earlier at this definition, whoops. Yeah, here is we basically end up, it's not sustainable. it doesn't have fidelity and quality, and we don't retain much of the impact. And that's not a deliberate choice. It just turns out, I mean, it actually is kind of a deliberate choice, but it's an unconscious choice. And that's what we end up with. And I'm not okay with that. I mean, I don't think we should be okay with that. Okay? Okay? All right. So, so I didn't talk about sustainability, but we can come back to that. But I guess one of the tensions is even when you're doing this consciously, especially if you're in a large country or even a diverse country. I mean, I said I was working in Rwanda. Rwanda is about as homogeneous as you're going to get, despite the Tutsi-Hutu thing. Actually, at least from an outsider, I can't tell the difference most of the time. And it's tiny. There's only 11 million people. It's not that big geographically. It's pretty homogeneous in terms of its. Even so, it's quite clear that I was working on a youth livelihood training model that there needed to be somewhere between 2 and 3 different versions of the model because of urban-rural and because of people who drop out of school and don't drop out of school, right? So that's 3 or 4 models right there. Okay. So how do you adapt and maintain fidelity at the same time? That's a big challenge. Okay. So we add that to the, to the mix. All right. So I'm going to share with you a framework, and we're going to go through it and apply it to scaling up for a particular model, the search home-based neonatal care model. I go through it step by step, but in reality, scaling up never works that way. It is really a nonlinear dynamic system with lots of feedback loops. I think you're going to see that a lot of what I'm sharing with you is common sense, but it's organized in a systematic way, and it's thought through. And I could talk about tools to how you do this, but I'm not going to go into that today unless there are specific questions. All right? So as I said, if you think about the basics, and I'll expand on this a little bit, what is being scaled up? What is the concept and the program, and and implicit in this question is what is the relationship to that to what you guys have tested that works? Okay, is it exactly the same, or what changes, modifications, simplifications need to be made to make it scalable? Okay, and I can disaggregate that question quite a bit. Okay, where is the scaling up to occur? So what's the reach? What's the location? What's the demographic group? And what's the impact? Should it be scaled up? So do you guys think the concept is promising or proven? And particularly, is this version promising or proven? Right? And how far away are you comfortable getting from what was proven before you think the evidence, you're selling something that you don't really know that works? Because it's, how much slack can you allow before this is not the same thing? Okay. How is it to occur? We'll talk about that in detail. And who's going to do it? Okay. By the way, Mark has this, and you can all have a copy. My only request is that if you cite it or use the slides, could you just give me credit? Okay. Or a reference. Okay. All right. So the tasks are, first of all, let's get ready and have a strategy. What is the model or the program? What are the goals? Pretty straight. Is it scalable? And if not, what do we need to do to change it? A strategy, and how do we make that circle that I showed you a few minutes ago work? Okay. This is pretty simple. Then we create the preconditions. So we take care of the politics. We take care of the capacity and the capability. And if we have more than one actor, we need to take care of the coordination mechanisms. Again, this is not rocket science. How do we monitor for quality and fidelity and flexibility or adaptation and ensure sustainability? So this is very simple, I think, anyway. Okay. So first question, we want to know, should the model be scaled up? What is it? Is it the pilot, modified, or simplified? And is there something about the social context which is going to require it to change? So I'm using social context in the broadest sense of the word. Basically, if you think of, if we drew a systems analysis of whatever issue you're working on, education, health, youth, agriculture, and here are the outcomes you're trying to achieve, there are certain things that are internal to your model that are driving those outcomes that you're affecting, and there are certain things external that you're taking for granted. So the question is, if you move to a different location or a different demographic, do those external factors change? And if they do, how does that affect the causality in your model? So you guys must use log frames, right? Right. So this is the classic. What are the assumptions in the log frame? And if you move to a different context, do they change? And if they do change, what are you going to do about it? Just roll with it, which we often do, or pretend. Now, the one thing I would say, and I'm not as up on some of, every time I talk to you, Mark in particular, who's my contact at JPAL, you guys are way ahead of where you were the last time, so I can never keep up. But in the past, at least, in my out-of-date knowledge of some of the research, because I'm always running around and it takes me a while to catch up, you haven't done, one of the areas could do better is haven't done a good job on this one. In other words, the log frames are fine, but do we actually test those assumptions? In other words, do we know, so let me give you an example, okay, again, using India. The model we're about to discuss was tested in a rural area of Maharashtra. In terms of the relative salience of caste and class, Maharashtra is around the middle, which is not surprising because it's kind of in the middle of the country as you move from north to south. It's not as liberal as South India, but it's much more liberal than North India, like Rajasthan or Bihar or some of those places, okay? So this is the village health worker model we're about to talk about, all women. In Maharashtra, it wasn't a big deal for Hindi women to go into Muslim homes or vice versa, and it wasn't a big deal for low-caste women to go into upper-caste homes and vice versa. When this model started to move to Rajasthan or Bihar, those issues did become important. So that was the change in social context that made a huge difference in terms of the external assumptions in terms of implementation. Does that make sense? Yeah? Okay. And I could give other examples. A classic one is urban-rural, which is transportation distances and population density. That it's one thing if somebody has to walk 20 minutes in peri-urban Delhi to get somewhere, or even in half an hour, and they're often shuttle buses. In a rural area where it could be 2, 3, 4 hours to get to a clinic, that can make a huge difference in demand and uptake, right? So that's another example, okay? So the one thing I just want to be clear on is that if you want to talk about scaling up, if this is your concept, basically the core of the model, that if you want to scale it up, you have to know the rest of this stuff. So for example, I'll often go to someone and say, so tell me about your model. And they say, well, we're working in a village, and we're working with village health workers or nurses or teachers or whoever the service provider is. And we teach them how to do this, and we also teach them to do it this way, which is really important. Right? Is there so for example, a lot of this stuff, pedagogy, I work on a lot of education ECD models. There's often a shift from a teacher-centered, top-down lecture, we fill your empty mind with knowledge, to most of the cutting edge in pedagogy is bottom-up, participatory, experiential, student-centered. Well, most countries don't do it that way. Okay? So if in that case, it's not just the curricula or the technical knowledge. Hi, welcome. I'm glad you could make it. Okay? Through sleet and storm and gloom of night. Okay? Have a seat. Okay. Mark said you were bringing Pepe's and Sally's pizza. I don't see it, though. No. Damn.
On the train, right?
Yeah, on the train. Well, actually, probably you'd get mobbed on the train, so that would be, you know, and they probably took it all. So that's a very good excuse. We believe you that that happened. Okay? Great. Okay. So anyway, the point being, whether it's pedagogy or if it's a family planning model or a health model where you're trying to encourage adolescents to use family planning so they don't have children at the age of 14 or 16, often treating them with respect as opposed to shaming them can be as important as the fact that you're distributing condoms or pills or whatever the technology is, yeah? But equally important is, so back to my story, so I talked to these people, and Blue has not told me to slow down yet. Are you sure I'm not talking too fast? Okay. I said, well, that's interesting that you're working in the villages. How did you get that to happen? Oh, well, we actually spent a year negotiating with the village leadership to allow us to do that. So I think to myself, so if you replicate this and you don't spend that year working with village leadership, is this going to work? Oh, no, we're just going to walk in and say, hi, we're here. We're from JPAL and MIT. You should let us talk to all your adolescent girls. And I'm sure that works every time, right? Okay? So I guess you get my point, yeah? All right? So, you know, front-end stuff is really important. And not just about the training, but permission and buy-in and back-end stuff. Okay? I mean, a lot of your models, and rightfully so, really emphasize incentives, accountability, monitoring, and supervision. Okay? That's key stuff, right? If that stuff doesn't get replicated, this stuff never happens, right? So it's a both and. It's not just like, what was the model that you guys did in Rajasthan with immunizations? It was a few years ago.
Lentils camps.
Right, the lentils camps, right. So, right, it was we give women lentils and stuff to come to an immunization camp, but we also incentivize So we're incentivized, so it's a 3 pieces. It's the immunization part plus the lentils for the moms plus the incentives and monitoring of the workers as they show up, right? You pull any of those pieces out, so the model is both this piece and a lot of this piece. The incentives pieces are down here, yeah? Okay. But also, what are the external assumptions? Cold chain, actually that model did work a little bit on cold chain too, okay, when it was necessary, etc. So all of a sudden there's a lot of moving pieces here, yeah? All right. Okay. So if we think about, now I'm going to illustrate this example with home-based neonatal care. So Delia, I've sort of gone through some definitions. I've talked about some frameworks for scaling up and how you think about it. And now we're actually going through step by step, and we're applying it to this particular model that I worked on. So here's all the concept stuff, right, which I'm not going to go through because you all can read. And if you can't, that's your problem, okay? The more important stuff, though, that I want to emphasize is this stuff down here, because this is not the concept stuff, this is the how. The how and the setup stuff, which is village health workers selected based on strict criteria based on testing. Why do I emphasize that? Because guess how they did it when they first got started? They went into a village, they asked the head of the panchayat, everybody know what a panchayat is? Village, okay. And they said, could you recommend 2 or 3 women to work? Who do you think they picked? Their nieces! Right? Or, you know, I mean, it was basically a client-patron kind of thing. Okay, and those weren't always the most qualified people, because they needed people with at least a 10th grade education, literate, numerate, and a couple other things, well-respected in the community. Okay, so that was, and actually started to administer a test. It was just a short test, but even so. It was performance-based pay, right, on top of a fixed stipend. So think about that. Actually, ASHAs are now doing that, but historically that wasn't true in most of the health system. Very different incentive system, very different selection criteria, and there was strict supervision and monitoring of performance, and also community and sensitization and outreach. This is really a key piece, right? So you go and start training village health workers. Who's going to get pissed off, right? This is where the politics already starts to come in. Whose interests are threatened by what you're doing? Okay, may not be a problem when you're working in a district or a block or just a bunch of villages. But you start to talk at scale, and the political problems get multiplied exponentially. Okay, in this case, the people who get threatened, you know this jargon TBAs, traditional birth attendants, right? Oh, they're going to be present at the delivery to make sure that the baby is okay, right? I'm not good with that. So they spent a long time making sure the TBAs were good with it, and we're not being threatened that this was a compliment, not displacing them. Okay? What happened here? Oh, I don't know why this is bad. So these were the key concepts. Was basically task shifting from neonatologists to community health workers or village health workers. And this is an example of a village health worker with her kit getting ready to make sure the baby's there. Just want to highlight a key point in this model that I'll come back to is I think you can see that these are vials of an antibiotic called gentamicin. It turns out that the single most important cause of death for neonates in their first few weeks of life is what's called sepsis, which is a systemic body infection. And it's easily treated if you just give a few shots of antibiotics. Okay? All right. So, whoops, wrong way. Still wrong way. And that's a picture of treating a baby. All right. And that's their logo. All right. So here's what happened, which basically when this organization started working in the 39 intervention villages, they first only focused on pneumonia, and they were able to bring neonatal mortality down from about 120 to about 100. And then they introduced a package of care and training which identified the 7 leading causes and not just one, and they were able to bring it down several years later to around 40, but most of that, you know, the numbers kind of bounce around, but most of that was in the first 3 or 4 years of the intervention. And by the way, I'm not going to get into the evidence for this, but this was published in The Lancet. It was done as an RCT, and it was, a few years ago, was voted the most important article published in The Lancet in the last 50 years. Okay? So we could have the argument about if you think the evidence is good later. Okay, so then we set goals for scale, and I was working with this organization by this time, and here's what they should include. So we've talked about this a bit. The scale in terms of the number of people or locations or demographics or coverage, the impact on key outputs and particularly outcomes, sustainability, coverage. The reason I harp on coverage is because if you graft, I'm going to use that jargon, a program onto an existing delivery system, most delivery systems don't deliver to the people who need it. So if you replicate through that system, you're going to replicate the existing inequalities in delivery. I had this great case where I worked on an occupational safety and health program in hospitals, well, the public health system in South Africa. And basically, health workers get needle pricks and all this kind of stuff and get HIV and other things. So they instituted a system that was based on a Canadian model in Africa, South Africa, to address this. And it was working, and they were going to scale it up. And I said, where are you going to scale it up to? And I said, well, there's 3 places: tertiary hospitals, secondary hospitals, and primary health clinics. So we're going to start with tertiary hospitals because that's where we have the capability. We have existing occupational safety and health committees are in place that can implement this. But those don't exist in secondary hospitals. It's pretty easy to create, and it's hard to create them in primary health clinics. And then I said, well, that's interesting. And where is the incidence of these, occupational safety and health? Oh, about 10% in tertiary hospitals, 10% in secondary, and about 80% in primary. Okay, so this is like, the old story about the guy looking for his keys. Everybody know that story, so I won't repeat it. Yeah, right? Which is, he looks near the light post, but he dropped them in the alley. So we implement where there's capacity and capability, but actually that's not where the need is. So again, coming back to your question, Sean, about setting goals, if you're fine with that, if you're fine that people in rural areas, marginalized groups, disadvantaged groups, or in the Indian context, scheduled castes, scheduled tribes, don't get this stuff, fine. But don't pretend you're going to national scale and those people aren't going to get this stuff because you're working through a system that can't deliver there. Just be honest about it. I mean, that's a policy decision. That's not my decision. I just don't want you to pretend that you're doing something you're not actually going to do. Okay? All right. So the goal for the HPNC was 500,000 villages in India and other undeveloped countries. Actually, they wanted to spread internationally, which they've done successfully. Replicate the community-based approach. So this is the what of the village health workers using they were very big on values, which was quite interesting. So coming back to our conversation about can you move from one type of organization with one type of culture and incentives to another, most of the time I work with NGOs, and most of them insist that they're rights-based organizations, and that an organization which is not rights-based, not just in theory but in practice, I'm sure all governments are in theory, can't do this. And actually that's an empirical question which I've never seen any evidence on. Okay, is that true? Okay, if you haven't drunk the Kool-Aid, can you still do it or not? That's an interesting question. Okay. They wanted the impact, same, to be 60 to 75% drop in neonatal mortality and infant mortality rates, which would allow India to reach the MDGs on that issue. They wanted to reach marginalized communities, such as scheduled tribes and scheduled castes, and they expected it to take about 5 to 10 years to roll out nationally. Okay. Now next, we assess the scalability of a model, and we do this less for the should question. The should question is important, but more how can we improve scalability? Okay. So these are 8 of about 20 or 30 factors of why scaling up tends not to work. One is the model not only doesn't have credible evidence of proven or promising, which is what you work on, but it also doesn't have an intuitive appeal or an emotional appeal. Okay? You can't just sell this, I'm telling you. Okay? You got to have this stuff too. Okay? It doesn't relate to existing policy priorities, so we talked a little bit before about the policy window, and felt need of beneficiaries. Okay? Go to rural India, ask them what they're worried about. Maternal mortality is actually not high on the list. Okay? Intensive in terms of process intangibles or tacit knowledge. So what do I mean by this? Which is what models, if you understand what I mean by that, are easier to scale than how models. Pills are easier to scale than process or injections. Okay? So the more process involved, more it's a social model as opposed to a technological model, the more difficult it is. Okay? Basically because it's hard to teach how, it's easier to teach what. Okay? And also our systems are technologically biased in favor of technology and not in terms of process. Is it complex or comprehensive? We talked about that. Do the losers have greater political clout than the winners, and can they block it? It's not easily grafted onto existing systems, so we've already talked about this, not aligned with existing culture, i.e. incentives, capabilities. And unit cost timescales is not within existing fiscal envelopes. So I'm sure that every time you design a model, JPAL researchers design a model, first question they ask is, what scale could this be? If the government adopted it, what's the budget constraint? And then they divide scale by budget constraint. This is the unit cost we have to work with, and then we design a model within that. Right, Sean? That's fantastic. I'm so pleased to hear that. I've never worked with an organization before that did that from the get-go. They usually think about it after the fact when someone says we can't afford this. Okay, so I'm truly thrilled that JPAL and IPA researchers don't do that, and they already start to think about the budget constraint up front. It's fantastic.
Okay. Actually, in our courses, we do teach that when you're doing your power calculations, for example, one of the most important components of your power calculation is what is the effect size that you look in, what is the minimum detectable effect size that you care about. And we actually ask them to do these kind of ex-ante cost-effectiveness analyses.
That's great.
However, usually those are based on kind of what are the alternatives and things like that, not what is this,
the scale,
the pie at the scale version.
Okay. Well, sounds like a good foundation to build on, huh? Okay. And last but not least, who's going to take this to scale? Is it going to be IPA? Is it going to be the deworming people? Is it going to be the ministry itself? Who actually will do all the stuff that needs to get done? So if you translate some, not all of these factors into a scalability assessment, first of all, is the model credible? Does it have hard evidence? And does it have endorsements? It turns out that if Bono likes your model, it makes a difference. One of the places that, again, I also think that you guys could contribute a lot is comparative advantage. It works, but is it more cost effective than other things that are out there? Okay, and since you're generating a lot of evidence that's out there, because there isn't other people really doing what you're doing, how do we know this is better what's out there? Who are the winners and losers? This is something that doesn't get addressed very often and often blocks it. Is it implementable in new contexts or new beneficiaries? So this is does the social context question change? How easy is it to transfer? This is the culture and capabilities question. And is it testable and affordable? So if you go to scale, how can you make sure it's still working? And on the one hand, are there either economies or diseconomies of scale? Who's going to pay for it? Now, the one thing I think most of this is intuitive, but if you have a question, I'll address it as best I can. But the one thing I want you to get is that about 90% of this is context specific. So when someone says to me, is this model scalable? I say, where and to whom, implemented by whom? You want to go from 3 villages to 3 districts using the same NGO? Very different question is from 3 villages or 3 districts to the whole country implemented by the government. Right? So, so that's a key question. Okay, so getting back to HPNC, let's apply the scalability analysis. As I said, it was credible and observed. It had solid evidence in the Lancet, so that's internal validity. It had a huge reputation. The Abe and Rani Bang have an international reputation. It had emotional appeal, because you had these little babies that were dying, so that always works, right? They actually, Abe Bang was raised on Gandhi's ashram, and that had a huge political credibility in India. And there were a number of leading pediatricians and neonatologists who supported it. It was very policy relevant, because India had a relatively high infant mortality rate, which was one of the MDGs. Actually, it was really funny. One of the reasons that there was a lot of interest in this model was because the Indian Prime Minister at the time, who's still the Prime Minister, Manmohan Singh, went to the UN Security Council and said, we want to be on the Security Council. And they said, and somebody piped up, I don't remember who it was, and said, well, your social indicators are crap. It's great that you're a world superpower and the economy's growing at, almost 10% a year and yada, 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 but infant mortality, da, da, da. So he was the finance minister, so he doesn't really know about this stuff. So he sort of turned to his aide and said, is that true? And they said, yes. Got back to Delhi, called the health minister on the carpet, said, you got to do something about this because you are jeopardizing our chances of having a Security Council seat. That's not the only reason, obviously, but it was really quite interesting. And as you may know, most of the ministers in India are not technical experts. They don't usually know anything about the portfolio they have. So that was a lot of political pressure to do something in this area, is being the point. Now, what about winners and losers? Well, it turned out that the first thing, UNICEF is very powerful in India on these issues, as in many countries. A lot of state governments have a UNICEF or UNFPA advisor. And UNICEF had its own program, which was called IMCI, or Integrated Management of Child Illness. The only problem with IMCI is it actually didn't address under 5. Okay? So the health minister said to the head of UNICEF in India, we need a program. And he said, we'll add an N to IMCI. And it became IMNCI. There was no content, no evidence, no proof. That's how it happened. And this became a competitor for HBNC. So much for evidence-based policymaking, huh? Okay? And more importantly, the Indian Medical Association was threatened by this model. Why? Anybody know? Highly threatened. Kind of strange, actually, but true. So in many countries, and certainly true in India, most rural health is delivered by what are politely called rural medical practitioners, or impolitely called quacks. And how do you know you got your money's worth if you're an ignorant, illiterate person and you go and give your rupees to this person? You get a shot. Could be saline solution, could be glucose solution, but if you got an injection, you got your money's worth. So you may recall that I highlighted that one of the key components of the technical side of this model was giving shots for sepsis. Except the people giving them are not people with MDs or, what is it, MBBH?
MBBS.
Thank you, MBBS, which is the equivalent in India, but we're 10th grade educated village women. Well, if you have a bunch of 10th grade village women doing what only doctors are supposed to do, even though there are no doctors in the areas these people are working, that undermines the financial and legitimacy of them, and they were hugely opposed. And they claimed that there were going to be huge side effects because all these women couldn't give injections properly, and there were going to be all sorts of complications. They had something like 100,000 trials with not a single complication. But again, when it's a conflict between vested interests and evidence-based policymaking, guess which one wins, okay? Though you could do a randomized trial on that one and see what you get, okay? The other questions about this model, was it too complicated? For example, with 6 weeks of training, okay, over a 6-month period, 1 week in the classroom plus 3 weeks in the field. It was very community-based. The bangs were considered very high quality, but could a less quality institution implement it with the same efficacy? And would it work in a government context? It was affordable within fiscal constraints. In fact, it was quite cheap. I don't remember the numbers. And also, it was aligned with a major government of India commitment to rural health called the National Rural Health Mission, and actually states were returning money. So this was actually kind of the ideal, the perfect storm, right? Policy window, high priority, plenty of money, and it actually turned out that the government decided it was going to implement an ASHA program, which was basically rural health workers, which this could be easily grafted onto. All right? So what do we do to improve scalability? We try to simplify the model by shortening the training, which the search people did not want to do. Document the tacit components, a divide and conquer advocacy strategy. So could we get neonatologists and pediatricians to say, well, this is a good model despite what the IMA is saying, and prove its external validity across locations and institutions, which you all call replication. And so it was tested in both other NGOs and the context of the government system. And this is particularly important. The test was sponsored by the ICMR, the Indian Center for Medical Research, which in India is the equivalent of the Good Housekeeping Seal of Approval, right? So again, this is a political process. Not just that it works, but these people said it worked, right? Was key. And these are the locations of the Anchor project, which was in a bunch of different places around Maharashtra. So it went from 39 villages to 91 villages, plus 6 slums, a much larger population, both urban and rural, and the results were pretty much identical. And you can see the changes. So I know I'm going through this quickly, but I've been talking for a while, and I don't want to spend all day having you listen to me. But basically, the roles that you need in scaling up is somebody has to sanction it, say it's okay for it to do it, and agree to do it, all the way from the top to the bottom, so from beneficiaries all the way up. We tend not to persuade beneficiaries to do things. We tend to get policymakers to agree and assume that everybody else falls in line. It doesn't usually work. Okay? Who's going to fund it and implement it and provide coordination? Who's got the capability and capacity to actually deliver? Where's the money coming from? And who's going to monitor at scale? And I would suggest that particularly here is also something else. that potentially JPAL or IPA could get involved in is that you may not have the scale and the resources to get involved in any of this stuff, but you're really good at monitoring. So why not monitor for fidelity at large scale? Why not just, as well as testing small scale interventions and concepts for efficacy? Okay? So there's 3 ways to scale up. Actually, there's 4 or 5 in my framework. One is expansion, and there's lots of different ways, but it basically means that the organization that did it grows to deliver at scale, and that would include an NGO getting bigger or sending out shoots like a spider plant or franchising. Replication, which is basically you give it to somebody else. That's the NGO transfers it to the government, and the government does it. And the big difference between the two is control. Well, actually, there's 2 differences. Right? In the expansion model, you retain control over things like quality and fidelity. In replication, you tend to lose control because you give it to somebody else. Okay? And it tends to be the case that in expansion, you have the capability, because you've done it at small scale, and what you're building is capacity. Right? That's why the distinction is important. And in what I'm calling replication, generally speaking, the large-scale organization has the capacity, but they don't have the capability. So you're building capability. See the difference? Yeah? Okay. And last but not least is collaboration, and there's lots of different ways to do collaboration. 2 of the most common is that you divide the project up by different pieces. So, one person does the training, another person does the delivery, a third person does the or organization does the monitoring, but they all can do it at the scale needed. They all have the capacity. They just, we have a division of labor by capability. And the other one is the opposite, which is that most of them only have small capacity, but they all have capability, so we achieve capacity by adding up lots of capacities. Small capacities added together make a large capacity. So that would be in the case like you'd implement through like 500 NGOs nationally or something like that. Make sense? Okay. So I wanted to make this slightly interactive since you've all been listening quite nicely and quietly. So we've already talked about capability and capacity. What about quality control versus adaptability? What are the pluses and minuses of expansion versus replication versus collaboration on quality control versus adaptability? We'll take them one at a time. So if I decide to scale up intervention or concept X through expansion, this organization is going to grow. Is that helpful for maintaining quality, or is it helpful for maintaining adaptability, or both?
No, neither.
Why neither?
Well, sorry, if I'm understanding that question. So the more people you involve, the less control you have over the quality.
That's true. Okay. But it is internal to your organization.
So
JPAL has grown by what size in terms of number of researchers over the last 10 years? Has the quality dropped? I'm sure there's only one answer to that question.
Of course. No, sorry.
It's all the same people, so I mean, we can't really.
Yeah, I mean, I guess if it's so if it's the same people, the similar culture,
Right.
then it would be advantageous.
Right. So you're both making the right answer and also giving the right nuance. So that was great. Which is that on the one hand, you do retain control, and so you have some control over quality. But often as organizations grow in size, they do go through changes. And it's one thing going from, Esther and Abhijit to, I don't know how many you got now, 100, 150, 200? 76 researchers, Is it as good? Okay. And what changes? And how do you maintain that quality as the organization goes from 2 people around a coffee table to 76 all over the country or over the world for that matter? Okay. And what about adaptability? Is organization X goes from, let's say, Nairobi to all over Kenya. Do you think that they're really good about adapting to local culture? Maybe. Okay. Well, let's contrast between the model where we scale up through 50 NGOs that are scattered all over Kenya. Okay. But it was only piloted in 3 NGOs in Nairobi. Okay. How does that compare on quality versus adaptability?
Greater adaptability, but lesser quality.
Right. Yeah. Because they have local knowledge, but as you diffuse, it's hard to get all these ducks to line up and do the same thing in the same way. And then you get into arguments, well, we're doing it locally this way because it's different here, versus, no, it's not really that different, and you're just lazy. Okay, you're diluting it because you don't want to devote the time and the resources. So how do you know which is true? That's a fun conversation, which you can have under collaboration. Okay. So again, I'm painting it more black and white than it is, and you were right to say that it's more nuanced. But what I'm trying to get you to think about is, if you think about what's the right way to scale up, there isn't the right answer, right? Because these different approaches have different pluses and minuses. So let me ask you this question. What types of model would you, in principle, if you could, want to choose expansion versus, all other considerations inside? Would you prefer expansion versus replication? It's kind of straightforward, guys.
I think it depends on your intervention.
Of course it does. That's exactly the question I'm asking. So what kinds of intervention?
That's the question you asked?
Yes.
I didn't hear that.
Okay, my
I was
bad.
sleeping. No.
Okay.
No, I mean, I think if it's a simple intervention, right, you can probably replicate it much more easily. If it's very complicated, you might want to think about it.
Exactly. So complicated, process-intensive, intangible, tacit knowledge, where the invisibles, where the how is more important than the what, you want quality and control, versus technological ones that are, silver bullets, drugs, pills, needles, technology, whatever it is, you can do replication. Or conversely, ones where local knowledge is important and context will make a big difference, you want to do replication to people who have that, organizations that have that, where if it doesn't make a difference, you're just as good with expansion. Yeah?
I mean, economies of scale are clearly important here as well.
Sure.
Because those don't necessarily map one for one onto the simplicity of the model, right?
Right, and that's why capability versus capacity. So which, again, expansion is good where it's easy to build capacity. That's not a very costly process. Replication, where you're basically grafting onto existing delivery systems, is better where capacity is expensive to build and capability is not that hard to transfer. So yes, there's all these trade-offs. So advocacy and marketing is basically the politics question. Who do you have to convince for expansion versus who do you have to convince for replication or collaboration? In expansion, it's basically your own organization. It has to get bigger. That's not completely true because you have to convince the board and you may have local partners that you have to work with. But replication, you got to convince at least one big organization, if not a whole bunch of little organizations. Or collaboration, and that's it's a different thing. Okay? And it's often, again, easier to convince people about silver bullets or things where you can see the intervention's effect or it has emotional appeal versus stuff that's invisible, that's less tangible, harder to measure. Yeah? And incentives in organization and culture, again, stuff which is very process intensive, where having good values, being mission driven is important to the intervention, then you might want to expand that organization or replicate to like-minded organizations versus transfer to ones that are very different. And obviously, Mark's point is extremely well taken. That is, unfortunately, these don't all line up together, right? So you're going to have to make trade-offs between these different choices. Does that make sense? Yeah. Okay. I've been talking for about an hour and 20 minutes, so I'm going to try to wind up here. I'm not going to go over the advocacy strategy, but we can just talk about it a little bit. In the case of HBNC, we had pretty good strategy, and we're able to leverage some really powerful ones, which was particularly the Planning Commission really liked this one, which is really the most important policy-making body in India. We already talked about this, but I think now you see how it all fits together, which is basically this question of expansion, replication, and collaboration is here. So given the model, right, the more processy stuff it's got in it, the more intangibles, the more, this is going to affect that choice. Versus if you're going to places that have diverse contexts, you might be thinking more about replication versus expansion of a qualitative model. But then you get into well, what if it's both? Right? What if it's a qualitative model where context matters? So how do you do both expansion and replication, or is collaboration the right way? And then in the collaboration challenge, What do you think the biggest challenge there is? It's coordination. How do you get everybody to play nicely together? Okay? Yeah?
Could you go back to the advocacy strategy slide?
Sure.
And explain a bit more what was done actually?
So sure, I'll go through it. So first of all, the big hook was that this would allow India to achieve the MDGs in infant mortality and to some extent maternal mortality without, and it wouldn't be able to be done without a high impact intervention. In other words, if we watered it down, which is what a lot of people wanted to do because they said it was too time consuming and too training intensive and monitoring intensive, that India wouldn't achieve the MDGs, and that's often a big sell in a lot of countries. Okay, so that was a key talking point. It had strong evidence. It was published in The Lancet. It had been replicated in multiple sites and locations across several states. So it was what I call robust and generalizable. I tend to use robust as across social context and generalizable across institutional organizational context. It had been implemented by the government in some success versus the famous IMNCI, okay, which had no evidence whatsoever, but was advocated by UNICEF. Again, legitimacy versus evidence, okay? The power of the site visit to Gadchiroli. So this is an ashram that is where Search is, which is 4 hours from Nagpur in rural Maharashtra. And you go there and it's very impressive. You know, I mean, site visits really make a difference. You know, they meditate for 2 hours every morning. It's very Gandhian. Even the doctors help clean up the site. People wear very simple clothes. I mean, it's really like you've gone back in time 50 years ago.
How is that related to advocating the scale-up of the program?
Because bringing ministers and key state secretaries to visit that site was often persuasive.
But as in, it's not a rational connect. That's not the model they're advocating, setting up ashrams or anything.
No, it wasn't. This was a model for health medical research. Not that it was in any way, shape, or form be delivered by anything that looked like this. But bringing people to see it in its original context was a very powerful experience for people. Okay? So we had our own experts, neonatologists, leading ones, and pediatricians. What's the big, I'm forgetting, at the top level hospital in Delhi? Ames. So we had several people from Ames who thought the model was great. We built a coalition with a lot of NGOs around the country, and we were able to get the Planning Commission and the National Health Systems Health Strengthening Resource Center on board. Okay, so basically we built coalitions, we had powerful messages, we aligned with existing policy, and we had people who could give us legitimacy, and these were the pieces of the strategy.
And the objective was to integrate this with the Ministry of Health,
ASHA system.
Okay?
ASHA system,
Okay.
which was being rolled out contemporaneously, actually. So what do you think happened? So we tried, so I went around the circle with Search, and guess what? The pieces didn't add up. Because they had a choice between the government system, which could reach 70% of the country at about 50% effectiveness, and they wanted to go through NGOs, which they agreed could reach at most 5 to 10% of the country with 100%, 90% effectiveness. What do you do? You want to build capacity or capability in the entire government system? You know how big India is? You know how many ASHAs they were talking about training? It was like 300 to 500. Remember, we're talking about 500,000 villages, one ASHA per village, 500,000 people. Changed the entire culture of the Ministry of Health. Okay? And they didn't want to simplify the model because they thought that would have a dilution of quality. Well, I spent a year working with them, trying to get them to agree to this, to something, and they finally said, yes, 70% of the country with 50% effectiveness was better than 10% of the country with 100%. The numbers were overwhelming. It was basically like 35,000 avoided deaths per year versus like 5,000 avoided deaths per year. Okay, so I thought that was a no-brainer, but it was really interesting politically that the piloting organization took a year to get there. Okay, just sharing that with you.
What were some of their arguments, or what were some of the conversations that made it not so obvious for them?
It's the right way. It's the right way to do it. This is what we proved. This is what we do. This is right. This is very big on a rights-based approach. All children have the right to a high-quality model, not a dumbed-down, simplified, diluted model. Okay, how are you going to implement that? I mean, that was my response, but that was where they were coming from. And basically, you know, it's sort of, I mean, I've had this argument with Esther, actually. It's sort of the classic version, which is, if you set the bar really high, if you don't set the bar really high, you're never going to get there. So we go with the gold-plated model, and we try to overcome all the obstacles to getting there, versus we make compromises and sell your soul, right? Because we can get half a loaf now for a lot of people. That was kind of their view, that it was sort of the, we hold out for the best, and we make it happen, and if it takes 5 or 10 or 20 years to do that, that's better than if we settle for half a loaf now, we're never going to get the gold-plated model. That was basically
In effectiveness, are you talking about effectiveness of outcomes or effectiveness of like the delivery of the model? Because okay, because I mean, I feel like it's a big difference. You know, some things if you do it half right, you get a third, like a quarter of the results, right? Or you know, that matters. And
well, let me ask you that question. I agree with you in principle, but do most JPAL research results actually demonstrate that fact?
I don't know. I mean,
I would bet not. In other words,
I mean, we had like
dosage type
Right.
evaluations. Where you
Right. So I guess my point, though, is that
varied treatments.
is for particularly for scaling up, that dosage stuff is really important.
right. Yeah.
And you want to think about that in advance. In other words, given the capabilities of the large-scale system, where are you likely to get the most slippage? And let's test where we really want to hold the line on quality and say, no, you can't compromise on this because it completely compromises your results. But yeah, slippage here is not that important. It would be better to do it this way, but this is key and this is not.
I mean, in theory and beginning in practice, we're working more and more with the Sean Powers model, which is basically, let's test this out in crappy implementing environments. And I mean, it seems like that would have been easy to do here. You basically get a handful of ashas, you know, or 100 ashas.
But
Right.
that's even like a little bit too late though, because then you're testing out in crappy models, but like if you're gonna test out in crappy models, you should already kind of know what are the key things that we want to hold true. So for example, with TKI right now, like we're testing out a crappy model, we're kind of playing around trying to figure out what we think is like the most essential component, but is it time on task? Is it like, I mean, it's just like there are a whole list of things, and if we know that, then I think this next phase would be more useful for scale-up purposes.
By the way, when we meet later, I want to have some time telling you about our Ghana replication.
Great, okay. So to make a long story short, so that I don't leave poor Jasmine hanging, okay, we had mixed success, which is that UNICEF really fought against it, the IMA really fought against it, there was a really strong medical mindset, and there was threats to medical prerogatives and livelihoods by having what's called in the jargon task shifting. At the same time, the Planning Commission did integrate it into the next 5-year plan, which was huge. And the Ministry of Health and Family Welfare equivocated, which was complicated by the fact that key leadership positions turned over. We had like 3 secretaries in the space of, or 4 secretaries in like 3 years. I mean, it was constantly changing. And the big pressure was to drop the injectable antibiotics and dilute the training. And that's exactly what happened. What happened was, we actually did have disaggregated evidence on impact, it showed that 40% of the impact was due to the injectable antibiotics, but the compromise was that for the first 3 years it would be implemented without the injectables. Okay, again, evidence-based policymaking, okay? Because the IMA, I don't mean to be ironic, but I'm just saying this is the reality you deal with, okay? We had the perfect storm, right? We had money, we had top policy priority, we had a delivery system being rolled out that was identically suited for this, which turned out, I didn't mention it, but the ASHAs are actually paid on performance-based pay, at least in part, okay, which was a huge revolution in India to have civil servants, all that. So you would think that all the gods were aligning, and even so, we didn't get the injectables for the first 3 or 4 years. I haven't checked back recently. It should be being rolled out about now. Despite that, it's going, and it's been also rolled out in Africa. So I think this was a huge success, but I think it wasn't perfect. Okay, that we ended up getting half a loaf or 60–70% of a loaf at scale, which.
So when did the national scale-up start?
About 3 or 4 years ago. But, you know, I mean, it turned out that it was complicated because OSHAs were being rolled out at the same time, and it turned out that they went through the same problems that they had experienced at small scale using village health workers, which is that the first set of OSHAs, roughly 30% were selected on corrupt basis. They didn't conform to the norms that were set out by the ministry in terms of the selection process. They were the niece of the head of the Panchayat Raj and blah. And then, so there were a lot of, but that's kind of normal stuff. So this is an old slide, but this is where it was of about 3 years ago. So key lessons. In this case, we didn't need to solve the issue because we had a favorable policy window, but you can't always take that for granted. That the NGO coalition evidence and expert champions were too weak to overcome bureaucratic opposition in medical professions. So again, evidence is necessary but not sufficient. And it's very hard to overcome personalized politics. One of the mistakes we made was we didn't do advocacy at the state level. And I think this for me was a really key takeaway, was that especially in a country like India where implementation and policy, not so much policy, but definitely implementation is done by states and local governments, and this is true in many countries now, right? That even if you go to capital X and you get the national policy to line up with your concept, that doesn't mean anything if it's the district or the states that are doing the implementation. If they haven't bought in, you got nothing. Well, that's not true. You got a national policy, which looks great on a website, okay? And this takes resources, right? 36 states in India. Now, it was mostly being rolled out in the northern half, so half of that, let's say 10, 15 states, but even so, somebody has to run around and talk to all those state governments. That's not just, you know, one person like Jasmine going, I mean, one person can't do that, okay? I only say that because I know you're going, okay? Not because you're Indian, okay? Okay? Need to, and not because I know you personally, because maybe you are capable of that, but most normal human beings aren't capable of that.
I'm not scalable, so that's...
Right, exactly. Well, actually, there are probably people at MIT or Harvard who would want to take a crack at that too, but that's a whole other question. Okay. Need to compromise on goals, impact, and method. Going to scale takes time. This is amazing, right? This was first implemented in the 1990s. The first Lancet article was published in 1995, and it began national scale implementation in 2011. Okay? My experience is 5 years minimum for the pilot and roughly equivalent for the scale process, minimum. Okay? And the same cost. So like I just did I was telling Mark I told you I was just in Rwanda doing evaluation of a scalability of a youth livelihoods project. It was mostly in Kigali. It was a $10 million project, reached about 15,000 kids. Potential demand is a few million, about 2 million. And our estimate is, and I'm using my words very carefully here, the cost of going to scale, not implementing at scale, but going to scale, doing all the advocacy, doing all the capacity and capability building, doing all the training, setting up all the infrastructure to get to scale would take about another 5 years and roughly the same cost, about 10 million as the original pilot. Okay?
And this is all cost effective?
Good question. So that's a funny thing. I wasn't doing an evaluation. I was doing a scalability analysis. So I had to do back of the envelope. So I was relying on existing evaluations, which were crappy. Okay, they didn't even do they didn't do RCT, they didn't do quasi-experimental. They didn't have pre-post or control group. Okay, but the person who did the midterm evaluation, which was mostly qualitative, estimated that cost was $600 per kid, youth who went through it, and then proceeded to say, I thought this was really funny, said, which is much lower than the average USAID youth livelihood training, which tends to be $2,000 to $3,000 a kid. And I'm thinking to myself, okay, why is that the metric? Right? USAID is going to pay for 2 million kids to go through youth livelihood training? I think not. Okay. You multiply 2 or 3 million by $2,000 a kid, or even $600 a kid, and you're talking, somebody can do that for me, $1.2 billion, which is like Rwandan GNP. Okay. I then ran some of the numbers, mostly on an Excel spreadsheet, so again, not rigorous stuff, and I came up with about $150 a kid, which was still a lot. But that was the ballpark we were in, was viable fiscal envelope was $75, $100, $150, not $600 or $2,000. Is it cost effective? Good question. One of the things in my report, which I'm currently finishing, is before this goes to scale, this needs, and this is a good, I mean, I'm often in, I don't usually have the privilege of working with you all, so I'm often working with models where the evaluations have been of mixed quality, and I spend a lot of time pushing for retro, you know, like, okay, fine, you've got a policy window, there's a lot of promising evidence, but you can't ethically go forward with this, at least without scaling simultaneously while having an RCT or something. And that's a tough sell a lot of the time, frankly. I mean, I don't have, this is the wrong group to complain to, because obviously you're not doing that, but I'm just telling you what I deal with a lot of the time. All right, so just sort of, I think where I want to leave you guys, actually I'll give this slide last, is if you want to scale up, you should know what the intangibles are and how important they are, right? This invisible stuff, if it's not a technology. What are the goals? I think that would be really interesting. Like anytime JPAL funds a research project or a member does it, if this works, what would the scale be? Just a paragraph or a table. What's the need for this? Then how diverse is it? What are the external factors that may be different to require changes, and do we document them in our research? Start with the end in mind and work backwards. So I guess you're starting to do this, but what is the crappy system you're going to scale up through, if that's what you're going to do? And design within that, and also generate evidence that allows for advocacy and simplification. So let me just give another example from India about the advocacy side. One of the other models besides HPNC I worked on was an adolescent reproductive health and sexuality education project, HRSE. By the time I was brought in to work on it, the pilot had been done, results looked good. The outcomes they were worried about was age of first conception, age of marriage, child spacing. For those of you who don't know, legal age of marriage in India is 18, and actual average age of marriage is 16. Okay, that's a gap between policy framework and legal framework and implementation there. Okay, etc. So by the time I got there, they had been trying to scale up this ARSH model, and guess what the results were? 7 states had outlawed it being taught in the schools. Why was that? Why do you think? Proven effective. This was actually a quasi-experimental design. What do you think conservative policymakers, religious groups, just people socially conservative in general worry about a model like this? You teach my kids about sex, and what are they going to do? Have more of it. So guess what the data showed on this? Didn't show anything, because they didn't collect data on this, because it wasn't an outcome they were concerned about. So I guess that's my point, is that, you know, you're teaching economics, development economics at Harvard or MIT, or you're in the public health school, you may be concerned about X. But for these purposes, there's a different calculus going on. And if you don't collect data on that stuff from the start, you're sort of left in the weeds, you know, well, with nothing 3, 4, 5 years later when you get the data. So again, who are the key stakeholders? What are the likely arguments you're going to get against this? Because just because it works, I can tell you, isn't sufficient. And can you collect data to address those arguments up front? Yeah? Okay. You know, the unit cost constraint and who's going to do the going to scale. So in terms of the going to scale, and I'll close on this, this is what I think the process is. So proof of concept, then testing the concept in a pilot, which is what you guys do a great job at, internal validity, testing external validity across both locations and organizations, which you do some of, which is great, dissemination, which you do some of, and so and then getting it into not just strategies, but policies, programs, funding, and buy-in from district and frontline implementers. So how far down the scale do you want to go? Or who can you partner with to work on that? Creating the preconditions for large-scale implementation, training, capability building, etc. Or realigning the regulations and legal system. Implementation at large scale, which you're clearly not going to do, but ensuring impact on key outcomes in terms of monitoring and accountability for fidelity and adaptation. Okay? So I guess what I'm saying is if you stop here, it's usually not enough. Okay? Or if you stop here and just do a little bit of this, it's usually not enough. So if you all don't do it, somebody has to. And generally speaking, this doesn't happen at all. And you're really good at this stuff. So, I'll leave you with that. Was that helpful? Like the silence is deafening. Well, you already knew all this, and this was the most boring 2 hours you've ever spent.